Thank you, Hartmut. I'm very happy to be here today. And these are my disclosures. First, I have to thank my colleague from Nice, Edmond Chiche, and Thomas Clouseau, who collect all this data from 12 centers in France. And we have collected data for 103 patients. Most of the patients, 98, received only one induction cycle, and 5 patients had two induction cycles. Then 44 patients among them had one or more consolidation. All patients were older 18. The median age, as you can see on the right, was 67. And 72 patients had MRC AML and 26 therapy-related AML. Cytogenetic ELN classification has shown that most of the patients were adverse, then intermediate, and only 2 were favorable. 18 patients received priorly hypomethylating agents. We studied the most frequently mutated genes, and they were studied for 74 patients and for 19 genes. And the more common was RUNX1, then I6L1, then TET2 and TP53, so more unfavorable genes. We have studied the adverse events, and some of them were not reported in the phase 3. That are the adverse events that are in blue here. And we have noticed in the whole study that the extrahematological toxicity was not so high. And interestingly, for patients, there is a very few percentage of alopecia and zero alopecia over the grade 3. Hematologic toxicity have shown neutrophil recovery above 0.5 10^9 to the liter of 29 days, and a recovery to platelet above 20 of 28 days. Early mortality have shown a day 30 mortality of 6% and day 60 of 8%. Among the 103 patients, 36 of them, a third, received a transplant. In terms of complete response, 59 patients had an overall response, and among these 59%, 55% of the patients had complete response. Here is shown the median overall survival that has shown a median overall survival after a short follow-up of 8.6 months, but the median survival was encouraging with a 16.1 months of overall survival for this very bad prognosis patients. We have been able to study the MRD of these patients by molecular or by cytometry. And among the 61 patients we were on response, it has been possible to study this MRD level for half of them. And among these 28 patients, 16 patients reached a complete molecular or cytometry response. On the right, you can see the results as it has been shown earlier for the phase 3 of survival for patients that has been transplanted or not. There is a large difference between those two curves, and the median overall survival is not reached for patients transplanted, and the median overall survival for others was 9.3 months. In conclusion, our French study confirmed the efficacy and safety of Vyxeos liposomal in high-risk AML patients in a real-life setting. The high rate of CR with low MRD compares favorably with previous reports using 7 plus 3 in elderly unfavorable AML patients and may explain the favorable outcome observed in patients after allogeneic stem cell transplantation. Thank you.
Well, thank you very much, Arnaud, for this presentation. Really interesting and encouraging data, and also, as we discussed, filling some gaps we have with regard to the data from the pivotal study. So very interesting data regarding MRD and also confirming the very good outcome after allotransplant. I suggest that we directly move to the next presentation by Professor Limoli, and then we have the panel discussion afterwards. So Professor Limoli was involved in generating similar data from Italian centers. So Roberto, we are looking very much forward to your presentation.
Thank you, Helmut, for the introduction, and thank you, JATS organization, for inviting me to this interesting symposium. These are my disclosures. Okay. Well, in Italy, we have treated 73 patients in the 3 Italian hematology centers in a compassionate use protocol. We've been able to collect data out of 71 patients from 31 centers. The treatment was performed according to the phase 3 trial published in the JCO. Those are the patient characteristics of our patient population. Median age was 66. The patients were stratified according to their previous clinical history. 18.8% patient had showed MDS-related changes, 31% of the patient the therapy-related AML, and 43.7% of the history of prior MDS. Almost 24% of the patient had prior exposure to hypomethylating agents. More than 56% of patients have abnormal cytogenetics, and the patients were also stratified according to ELN risk score. As you can see here, almost 90% of the patients had an intermediate or high risk score. Okay, after first induction, complete remission plus complete remission and with the incomplete hematological recovery was achieved in 64.8% of the patient, and this percentage was increased up to 70.4% at the end of the treatment. Very interestingly, we've been able to assess MRD after first induction by multicolor flow cytometry and by analyzing the expression WT1. As you can see here, 37.5% of the evaluable patients achieve MRD negative CR by flow cytometry and 53.8% by assessment of expression at WT1. With the median follow-up of 11 months, the overall survival at 1 year was 68.6%. We've been able also to look at the outcome in patients carrying FLT3 ITD and TP53 mutations, and we didn't find any difference, statistical difference in terms of CR or overall survival, although I should say that the limited number of patients carrying FLT3 ITD mutation prevent to draw any firm conclusion, and this data should be confirmed in a larger series of patients. The cumulative risk of relapse at 1 year was 23.6%. However, when we look at the relapse rate of patients, the 20 patients receiving allogeneic stem cell transplantation in first year, as compared to patients who did not receive transplant, we found a statistical difference between the two patient population in favor of allogeneic stem cell transplantation, of course, and a predictive factor for the relapse rate was there was a trend toward a lower relapse rate for patients achieving MRD negative CR. This relapse curves translate in a different survival curves between patients receiving allogeneic stem cell transplantation in first year versus patients who did not receive transplant. At 1 year, overall survival in patient transplant was 100% as compared to 70.5% in patients not receiving a transplant in first year. And the multivariate analysis confirmed that performance of allogeneic transplant in first year was the only independent predictor of overall survival. As for the toxicity profile, despite the rather long-term to hematological recovery after first induction, 38 days to achieve 500 neutrophils per microliter, 28 days to achieve 25,000 plates per microliter. Despite this data, the 60-day treatment-related mortality was 7%. And the grade 1 adverse events were mostly infection with fever of unknown origin, sepsis, and pneumonia. We also observed in a quarter of a patient a self-limited and self-resolving cutaneous rash, which was not described in the original phase 3 trial, and a very low number of patients experiencing alopecia. So in conclusion, overall, the results of Italian compassionate use program confirm the results presented in the original phase 3 trial by demonstrating that VYXEOS is an effective induction regimen for high-risk patients. VYXEOS can induce a good quality remission by considering the significant proportion of patients achieving MRD negative CR with an acceptable toxicity profile. And perhaps the lower incidence of severe complications, especially extrahematological complications, may reasonably increase the number of elderly patients receiving subsequently consolidation with allogeneic stem cell transplantation. Of course, further studies are needed to identify factors predicting response and the role of MRD assessment.
Thank you, Roberto, also for this very interesting presentation. Another very interesting and very valuable data set for CPX-351 in a real world setting. I mean, we are all aware that comparing trials and in such cohorts is difficult, and there are caveats to such comparison. Nevertheless, I think I would like to start the panel discussion in asking you, do you think the data you showed are consistent and confirm all the beneficial effects we have seen in the pivotal study? Maybe, Arno, you would like to start. Maybe we structure the discussion first focusing on efficacy, then on safety.
Yes, Hartmut, despite a shorter follow-up, as you mentioned, response and survival are, I think, consistent with the phase 3. And we are very, very impressed in my department by the especially good results of allogenic bone marrow transplant when it's possible for high risk and elderly AML. And when we are looking to the results, I think that around a third of this heavily affected population has been transplanted, and that is very, very hopeful. And on the other side, the we can notice that there is a higher but manageable hematologic toxicity and an extra hematologic toxicity that seems less important than with the 7+3 or other schedule we are using currently.
Roberto?
Yeah, I share with the same feelings with Arnold, and we were impressed by the low rate of extra hematological toxicity during induction consolidation, very low number of patients experiencing severe mucositis, and this might be important in view of subsequent allogeneic stem cell transplantation. In terms of efficacy, I think that our data, although the two trials cannot be compared properly, reflects what has been published in the phase 3 trial, and especially the significant number of patients achieving a CR. We and the French study, the Italian and the French study demonstrated MRD negativity in a significant proportion of patients, and those patients can proceed to allogeneic stem cell transplantation. And despite the relatively short follow-up, 100% of surviving patients at 1 year, I think is rather impressive.
Yeah, I'm also impressed by the data after allotransplant, and I mentioned in the beginning, probably two variables. That is a better clearance of leukemia prior to transplant and less toxicity. So where do you think is it MRD control, less toxicity, or both variables that contribute to this really better outcome after allotransplant? So what is your interpretation, Arno?
It might be both, I think, but and also we have made progress and in treatment around bone marrow transplantation, and that is a benefit also for those patients. And in our center, we are always looking if a transplant is possible for the patient that can receive the CPX, because it's the more impressive results. Even if the studies are not comparable, they are all sending the same message that for high risk population, CPX and then transplantation can change the overall survival.
Roberto, this is also your impression?
Yes, it's my impression. I think that both a deep response, achieving MRD negativity, as well as a low incidence of extra hematological toxicity, might account for the good results of allogeneic stem cell transplantation.
Just as a brief summary, so where do you see the benefit, the major benefit of your data from the real world setting compared to the data from a controlled clinical trial as it is published? Where do you see the main benefit now for the community?
Well, I believe that the VIXIOS might change the approach, the treatment for high risk AML, and because it might represent an excellent platform to bring as many patients as possible to allogeneic stem cell transplantation. And this is true also for patients over the age of 60. In our experience, the median age of transplanted patient was 65. In addition, emerging data are showing that CP351 can be used with success in patients under the age of 60 as well, by considering that they are patients with high-risk disease with therapy-related AML or MRC AML. So regardless of the age, CPs could be used in this patient population.
So regarding the methodology, so we have discussed some, advantages of real-world evidence data. Where do you see major disadvantages of your data sets?
Our real-world data are considered that less scientific value for an approval, but they contribute to the knowledge and confirm the results of the phase 3. And one of the advantage is that the selection of the patients in the real world is not so strong, so it's complementary. I know it will not be useful for an approval, but it's very important to add and to confirm.
Roberto?
Yes, first of all, I would like to say that randomized clinical trial are a stringent requirement for regulatory authorities for approval and wider use. However, the patient might be highly selected, for instance, for age, as we discussed, comorbidities or fitness. Real-world data are post-approval studies providing results that are collected outside conventional randomized clinical trial, and they have pros and cons. For instance, patients in real world data are not highly selected. The speed of data production and real world studies can generate larger number of data. Cons are, for instance, selection bias, for instance, or accuracy of data collection interpretation. However, changing the subject, I would like to give an important example of the importance of real-world studies. If we consider recently published papers in the New England Journal of Medicine on the real-world application of anti-SARS-CoV-2 vaccine in Israel, which fully confirmed the randomized clinical trial published a few months ago, and also extended the observation of the prevention of the severity of the disease, and also added the notion of the prevention of the incidence of infection. And this is reinforced the importance of real life data.
So, yeah, I think that was a very good discussion. Any final take-home message for the audience, Arno, Roberto? If you pull together the data from phase 3 and the real-world data sets that you presented?
I think that among this study, phase 3 updated and real world, the take-home message that there is now some hope for the high-risk AML and elderly patients. That is the most important thing. That in the recent years, this is a large progress. There is also some other progress with other drugs, and it's good for patients affected by this disease.
Roberto?
Oh, yeah. Although the three trials are not directly comparable, I think for the first time we have a drug formulation which demonstrated superiority to conventional 3+7 chemotherapy. And also I would like to stress there a significant proportion of patients, in our experience, approximately 30%, could be brought to allogeneic cell transplantation with MRD negative CR. And despite the age, the median age of 65, we did not observe any transplant-related mortality.
So let me just briefly summarize. So the real-world evidence plays a crucial role in advancing our understanding of treatments and diseases beyond phase 3. I think we have seen two very nice examples of this crucial role of these data. Patients with high-risk AML, defined as newly diagnosed therapy-related AML or AML-MRC, have historically poor prognosis. The phase 3 data shows that Vyxeos results in an improved median overall survival over conventional chemotherapy in these patients, and these improvements were maintained at 5 years of follow-up. And the French and Italian real-world studies provide additional insight not included in the pivotal study, including a high rate of CR with MRD negativity, and importantly also additional safety information. So the real world evidence confirms the efficacy and safety of Vyxeos in high risk AML in a real world setting. Yes, tell us what you think. Please follow the instructions below to complete the online evaluation. But let me first thank Professor Pigneur and Professor Limoli for these very interesting data, very valuable data from the real world settings in France and Italy. And I would like to thank the audience for attending this interesting symposium. And the three of us, I guess, sincerely hope that we can see us soon in person again. So thank you very much again. Bye-bye.